AAP California Chapter 2 Vice President, Dr. Grant Chrisman.
It's my pleasure to introduce my colleague, Dr. Jonathan Warus. He is an adolescent medicine physician who specializes in care for transgender and gender nonconforming youth, HIV prevention for adolescents and young adults, and LGBTQ health for youth. He is an assistant professor of clinical pediatrics at Children's Hospital Los Angeles and the USC Keck School of Medicine. Take it away.
Thank you very much. Thanks for having me here. So I'll go ahead and share my slides. Okay, so the talk that I'm going to do today is focused on teenage suicidality. And so really for this talk, I hope that people get more information, learn more resources to be able to address these issues with your patients. In adolescent medicine, we see a lot of mental health concerns pretty routinely in our patients. But for myself, since I work more directly even with the LGBTQ population, I also see mental health concerns even that much more. And so really that's where my interest in teenage suicidality comes from. It's just that I see it a lot with my patients. It comes up frequently. Obviously, with increased concerns about mental health during the pandemic, we need to try to really remove the stigma and discomfort around having these conversations if we're really going to provide the best service to our patients. Obviously, this discussion can be somewhat sensitive and it may be distressing for some in the audience. Just reminding people to take a moment for yourself if you need to during the talk. The learning objectives, really, I think the things that are the most helpful is to understand the trends in teenage suicidality over time and what we've seen or what we know so far from the pandemic. Look at how certain factors can put people at increased risk for suicidality, and then really focusing on strategies to prevent, recognize, and respond to youth who are experiencing suicidality. Before we start in the discussion, it's always important just to know what we're talking about. There's a lot of terms around suicide, and so just making sure we're all on the same page. So when people say suicidal ideation or SI, we're really describing people when they are thinking about considering or planning to die by suicide. There are two different types of SI. There's both passive and active. The passive thoughts are really much more of thoughts about death in general, thoughts about people would be better off if I'm not around, much more abstract thinking around suicide. But really when people have active suicidal ideation, it's where they have a specific plan and intent to die by suicide. So it's much more concrete thinking. And so there's a difference in risk between these that we'll discuss later. A suicide attempt is a non-fatal, self-inflicted destructive act with the explicit or inferred intent to die, whereas when people just say suicide, they usually are referring to death by suicide, which is a fatal self-inflicted act with the explicit or inferred intent to die. So my talk title includes the word suicidality, so people can get confused on what's going on, but really suicidality just refers to all suicide-related behaviors and thoughts. So it encompasses everything from ideation to attempts to death by suicide. So suicidality is really just more of a bucket term for everything. And so what are we seeing in youth in terms of suicidality? So the Youth Risk Behavior Survey from the most recent year, from 2019 data, looked at ideation in blue, reports of plan, and reports of suicide attempts in the past year. And we see that rates for all three aspects of suicidality are higher in females. So ideation, plans, and attempts. And really nearly 25% of females within the YRBS in 2019 reported having ideation in the past year. Again, that doesn't differentiate between active or passive ideation, it's just ideation in general. And then looking at attempts, about 10%, 11% of females, and almost 7% of males reporting a suicide attempt in the past year. And so this trend has stayed pretty similar over time, where females in this dotted line up here have a higher percentage of people in the YRBS who have endorsed a suicide attempt in the prior 12 months. And that for males is down below with kind of the average for everyone in between. And so you can see there has been an increase in reported suicide attempts in youth through the YRBS. When we look at deaths by suicide, so we're talking about the suicide rate, so people who have died by suicide, instead of females who have higher attempt rates, actually males have a higher suicide death rate. And oftentimes that is because males tend to use more lethal methods or lethal plans when considering or carrying out suicide attempts. And so they tend to have actually a higher suicide rate. And then down here in gray is the female suicide rate. Again, for overall everyone from 5 to 18, the rate has been going up, especially in the past few years. And so it's been an area of concern even before the pandemic. When we look at suicide attempts by race and ethnicity, there's been discussion that there's a specific increase in Black identified youth who have attempted suicide in the past year. And so really seeing within the past 4 to 5 years, really seeing an increase in that population, where actually in the Latinx population, it's been dipping a little bit, and then white identified individuals at the bottom. This is a little bit more complicated of a picture when we talk about race, and so I have a slide just specifically about comparing Black and white youth. So when we look at, again, for suicide incidents over this 15-year period that they looked at, boys have a higher number of people who have died by suicide compared to girls in general. And then when we look at white youth, the rate is higher per 100,000 than for Black youth. But what they did in the studies, they actually also looked at it by age, which is where they saw something much different. So what they saw was that actually for people between the age of 5 and 12, that Black youth actually had a significantly higher incidence of death by suicide, with almost twice the rate of deaths by suicide compared to white youth. And then when they looked at older ages from 13 to 17, Black youth had significantly lower incidence of suicide. And so seeing that it was about half the risk actually of having death by suicide. And so and then this trend also was similar when they looked at males and females, and it also didn't change over this 15-year time period, this trend in general. And so, there's no clear explanation. Some have posited that for older age ranges, that Black youth are at higher risk for death by homicide. And so that may actually be one of the reasons why older youth experience lower incidence of death by suicide. But this is something that really, I think, calls attention to the fact that Black youth, even though we know more white youth are dying from suicide, that really proportionally Black youth are at increased risk. And then looking at overall death rates for those who are 15 to 24 years of age over the past 20 years. So the top 3 causes of death for youth, they are motor vehicle crashes, suicide, and homicide. So if we look back in 1999, motor vehicle collisions was way up here, and suicide way down here. Motor vehicle collisions, at least the death rate has been declining pretty significantly over the past 20 years, whereas suicide has actually been increasing, and homicide rates have been fairly steady over that time period. And so what we've seen is that actually suicide, going from the 3rd leading cause of death in 1999, is now pretty much tied for first with motor vehicle collisions in 2019. So definitely concerning trends. And so then, of course, right, this doesn't even take into account anything that's happening around the COVID-19 pandemic. So there's been a lot of things in the media. So this example through NPR of saying that kids who are already trying to cope with mental disorders are really spiraling as the pandemic topples the support systems that already were struggling. And then this in Time magazine saying that even though kids may not suffer from illness with COVID, that the effects on their mental health is continuing to deepen, and that really older children who understand what is happening with the pandemic will likely require more care than toddlers related to the pandemic who aren't as aware of what's going on. CNN telling parents to pay attention to your kids' mental health. And the New York Times really trying to help people to have resources on how to deal when adolescents are having suicidal thoughts. And so this is something that's in the media a lot. And so I think it's always nice to have youth voices. I have about a 4-minute video clip of youth discussing what their experience has been, and particularly around mental health in the pandemic.
I'd say 6 months ago that I was pretty much a typical teenager.
I had this anxiety and stress of school.
Stress between school and extracurricular activities.
My mental health was better than it had been in a long time.
I was pretty happy most of the time.
I was just waiting to hear back from colleges, very excited. But,
COVID-19 can be characterized as a pandemic.
The coronavirus is a pandemic.
Many schools around the world, as you know, have shut down.
It's going to have a huge impact.
Right now, with the coronavirus and quarantine and everything, I'd say I've kind of retreated to a more isolated version of myself.
I definitely feel a little more frustrated and sad.
You start to worry about your future, and you start to worry about, am I ever going to see my friends again?
I'd say especially in the months right before the virus, I was really branching out at my new school and making connections, but I do feel as if I've fallen back.
Just really not knowing how things are going to turn out and just rethinking your future and your life, and it really took a toll on me.
What's been worrying me the most during the pandemic has been getting sick, or my family members getting sick.
I'm very, concerned about being a carrier of the virus or bringing it home or spreading it between people by going out.
When you're isolated by yourself, you're really just alone with your thoughts.
I've never said this before, but I miss school. I'm worried that it's just going to extend longer and longer, the closure.
I definitely know a lot of people who are struggling with depression and anxiety.
Especially, I think, for transgender people, I've been hearing from my friends, looking at your own body image in a camera or listening to your voice, especially for people that haven't made transitions yet, is very dysphoria producing.
I do have some friends that suffer from some mental health issues, and they do seem a lot more down now because of the virus.
I also have a friend who has some family troubles, and I feel like her stress has been amplified now that, with quarantine and stuff like that, not being able to see her also makes it worse because we can't really talk about it, and I can't really comfort her the way I would be able to if we see each other face to face.
I do think that it's possible that technology does play a role in the fact that my generation is more likely to suffer from mental health issues.
My, 15 years old and younger self was very much influenced by social media and seeing people live their perfect lives.
I feel like sometimes that might make people seem like, oh, that person has a wonderful life.
I think social media can absolutely help build connections between kids.
I constantly message friends, I see their posts, I like their posts. I like to keep up with what they're doing, especially now in a time where I'm not with them every day like I would be in school.
I have family members from other countries, so it's helpful to talk to them.
Technology is just evolving in our day-to-day life now, Zoom and social media, and I'm very grateful for that.
I would tell a person younger than me who's struggling with a mental health issue like anxiety that even if it feels safer to keep to yourself, to ask for help.
Take a little break off of social media because it does have a lot of sensitive content on there. This isn't the end of the world. You're gonna get through this. Even creating a vision board of what you want to do 5 years from now, will really motivate you to think more about the future and think more about the possibilities in the future. I think that the best way to go through anything is to talk it through and just, it's always better when you have someone's hand to hold.
I think it's always important to keep youth in the picture and really, hear from their experience.
I'd say 6 months.
So what did we hear from that? We heard people talking about depression, anxiety, stress, being sad, feeling alone and isolated, trying to connect with friends using technology, social media, things like Zoom. Also, one person talking about gender dysphoria and how that's exacerbated by technology, missing things, feeling frustrated, worried about getting sick, worrying about the future, not knowing what's going to happen. And so, you know, a lot of people have concerns. What is this doing to the risk for suicidality for youth with all of these things happening and escalating over time? A recent survey to youth specifically asking what they've had challenges with during the pandemic actually looked at the first concern was actually academics and work habits. So their first concerns were actually that a lot of people are struggling with school, right? A lot of people went to virtual school and they either weren't prepared for it, didn't know how to actually optimize working from home and not being with their peers. And then second is mental health. So really the top two concerns, you know, a lot of things that the AAP has also been very involved and vocal about are things related to school and things related to mental health. So it's definitely weighing on kids. And if we look over here, this model just kind of talks about there's all these things happening in the pandemic, all these different things that weren't present before, or at least are amplified, and really saying this isn't the only thing that's going to contribute to suicidality, right? It could potentially worsen underlying existing psychiatric conditions, or it could be causing new psychiatric conditions for people. But we also have other things to consider, like biological risk factors, psychosocial risk factors for suicidality. Also things like the immune-mediated mechanisms that we know around depression and anxiety, things like ACEs, adverse childhood experiences. So there's a lot of different things that really could contribute to increased vulnerability to suicide. But really, it's not only going to be the things in the pandemic, but how is this actually playing out? We have some data, not a ton yet. This is data from nationwide from the United States between the months of January and October over the past 2 years. So they compared 2019 in the solid line to 2020 in the dotted line. So if you look at 2019, we see kind of the normal variation we normally see throughout the year, where in the winter months, we tend to see more reports of anxiety and depression. So there was an increase in the number of visits to emergency departments related to mental health for those under 18. So we're seeing that during the winter. During the summer, it tends to decline and then goes back up when we reach into the fall and winter again. And so in 2020, what we actually saw was that it was actually exaggerated over the winter prior. And actually, when we were heading into the pandemic, the number of visits dropped. We know the number of emergency department visits dropped overall of people trying to stay home in quarantine. But then as things, you know, started to progress with the pandemic, people continued to really seek care in emergency departments at the same rate as they were the year before, even with the overall decline in the number of emergency department visits. So really, when we're just looking at when people are coming in for emergency care related to mental health, we don't see an overrepresentation of mental health, but that there's a lot of other factors to take into consideration. In Texas, they did a study looking at their emergency departments and in their pediatric emergency departments, and they actually were doing routine suicide risk screening for youth who came in between the ages of 11 and 21. And so they compared the reports of suicidal ideation in the past month between 2019 and 2020. The rates were not significantly different. It was 15% and almost 17%. And then when they looked at suicide attempts in the past 3 months that were reported, about 3.5% to about 5.5%. So an increase in both, but not a huge jump. But what they looked at then was by month. So the top one is looking at ideation in the past month. The bottom is looking at suicide attempts in the past 3 months. And they compared January through July, where 2019 are these little gray bars on the percentage of positive screens for ideation, and then the black would be 2020. And what they saw for suicidal ideation reports is that actually in March and July were the 2 months where it was significantly different. And for attempts, it was February through April and July that had significant differences from the year prior to during the pandemic. And so looking at what was going on during these months in Texas was obviously the pandemic started late February, early March, and they began lifting some restrictions going into May, where then they actually saw the rates being pretty comparable to previous. And then when they started restricting again due to increasing cases over the summer, they actually then saw it become statistically significant again. And so this is just showing that, people's reports of suicidal ideation attempts when they're screened by going to the emergency room, that we were seeing more people endorsing distress or endorsing these things during months where it seems like the restrictions were in place around the pandemic. This is a quote from the American Foundation for Suicide Prevention, because there's been a lot of confusion about all of this, and really just clarifying that we do not have nationwide suicide data. So we don't have death by suicide data for most of the COVID-19 pandemic yet. And so claims about increasing suicide rates, or actually death by suicide, really, we don't know that yet. It's not really based in the data that we have. And so really just pointing out that yes, we are seeing increased distress, and that can contribute to feelings of depression and anxiety. And mental health distress is linked to suicide, but it's also distinct from suicide. It's not the same thing as death by suicide, which we know is much less common than other aspects of suicidality. And so overall, kind of what risk factors do we know exist for suicidality? So there's a lot of risk factors on what can place people at higher risk for suicide or for suicidal ideation. So there are some fixed factors, things like having family history, actually being adopted, having a male gender, having mental health problems in the family, identifying as LGBTQ, being a victim of abuse, having a previous suicide attempt, and then also if people have underlying mental health problems already, so things like sleep disturbance, PTSD, substance use can also increase people's risk. Then there's a lot of social and environmental factors. So kind of what's going on in their life, if they're experiencing bullying, how's their relationship with their parents? Are they experiencing homelessness or in a group home or in a corrections facility? Are they having difficulties in school? Do they have significant adverse childhood experiences that they've been through? Is there a firearm in the home? So these are other factors that can increase people's risk for death by suicide. There's also more immediate factors. So things like acute agitation, having a recent stressful life event, or acute intoxication. And so if we think about COVID-19, right, these are things that are being accentuated, things that we're hearing more. So we're at least hearing more and more of these certain risk factors. We just don't have the data saying that more people are dying by suicide because of this happening yet. And then what the area that I work specifically in is LGBTQ youth. And so there are a lot of things in these risk factors that are overrepresented within people who identify as LGBTQ. And so since this is a big area of passion for mine, I wanted to talk a little bit about suicidality and LGBTQ youth specifically. And really the thinking around why there are higher rates is really related to minority stress. And the fact that being part of a minoritized group, such as identifying as LGBTQ, leads to stigma for being seen as other or outside of the hetero-cis normative society, and experiencing macro and microaggressions, discrimination from other people as they walk through their lives, and having over time an additive stress from nonconformity with what the dominant culture is. And we know that this can increase rates of things like anxiety, depression, suicidality. And so this whole model really kind of explains that just by being part of a minoritized group and outside of the dominant culture can actually have an impact on people's health. One thing that's unique, so we have all different types of minority groups, but LGBTQ youth are a little bit unique in the way that they do not have active support and modeling from their parents. So yes, someone's parent may identify as LGBTQ, but it's going to be at least less likely than, say, they share the same race or they share the same religion. And so their parents don't know how to deal with the stress and the things that come with identifying as LGBTQ, and they can't teach that to their children. And so youth look to celebrities, they look to social media, and that's really where they get their support. That's where they get their modeling, their mentoring, is really people who are not physically near them. And now with the pandemic, they have even less access to people who are physically near them, like friends and everything. And so just knowing that all these things are really compiling for populations that are already at risk. In 2019, through the YRBS, when we look at sexual orientation, since at least the YRBS has added in sexual orientation questions, is that those who identify as heterosexual over here have lower rates of all three aspects of suicidality, ideation, plans, and attempts. People who are unsure of their sexual orientation are kind of in the middle. And then people who identify as lesbian, gay, or bisexual they've reported 50% of suicidal ideation in the past year. So very, very high rates, almost 25% of people reporting a suicide attempt in the past year. And so really, really high rates that we see within LGBT populations. And so LGBT youth have 3 times the risk of expressing suicidal intent or plan, have 5 times the risk of suicide attempts compared to heterosexual youth. And if people report family rejection, they actually had over 8 times as likely to report suicide attempts. And so we know this social connection aspect in family is really, really important. Trans youth are oftentimes just lumped together with LGBTQ populations, and so we at least have some specific suicidality data from transgender adults, and really showing that 40% of transgender adults report at least 1 suicide attempt, which is 9 times that of the general population, and 92% reported suicide attempt before 25, so really happening really even at young ages. And so, this can be a very obviously depressing thing to go through, all of these negative aspects. So what is protective? What can help? So things we know that can help against youth suicidality are connection with parents or a caring adult. So the Family Acceptance Project is an LGBTQ positive organization to try to help parents to be supportive of their youth. But I would argue that doctors also, right, are a caring adult where we can be that person who creates a safe environment for youth. Also, fostering good connections with schools, with peers, having gay straight alliances or gender sexuality alliances where we can try to have anti-bullying campaigns, getting people involved in extracurricular activities, and also having decreased access to lethal means, which we'll talk a little bit about when we talk about safety planning, and also knowing that if we can increase certain skills for youth, increase their emotional intelligence, that we can actually increase their protection against suicide. So those are things that can happen through therapy and through discussions. So what should we be doing? Like, what should we be doing for screening, for responding to all of this that's happening? So for screening for depression, so Bright Futures recommends that pediatricians screen all of those from 12 to 21 for depression at annual visits. The USPSTF also recommends from 12 to 18 to do routine screening, and they just cited insufficient evidence for younger ages for routine screening. And really, when possible, screening should occur separate from parents. So with a lot of adolescent topics, we try to get youth alone if we can, but keeping in mind that safety takes precedence over confidentiality. So youth need to know there are limits to us keeping everything confidential. If their safety is at risk, we must inform their parents or potentially call 911 or whatever we need to do in the moment. So for screening for depression in general, we usually recommend using the patient health questionnaire, the PHQ, either 2 or 9. So the PHQ 9, there's a specific version that's modified for teens, that's for 11 to 17, and it's a 9-item questionnaire. The PHQ 2 is basically just the first 2 questions. So if people want a shorter screener, they can use the PHQ 2, where it's asking during the past 2 weeks, how often have these symptoms bother you, from not at all to nearly every day? And so possible scores for the PHQ-2 are 0 to 6. If you have a score of 3 or greater, it's recommended to then follow up with the full PHQ-9. In our clinic, we like just using the full PHQ-9. It doesn't take that much more time for the patient to fill out. And it also includes extra questions at the bottom that there are 2 questions that specifically also screen for suicidality. And so you also can screen for that at the same time. So that then you're also kind of addressing different aspects. There are in-depth scoring criteria I'm not going to go through, but then it will give you the severity of depression. The other cool thing about PHQ-9 is you can use it over time to monitor response to treatment. And so it's really, really helpful. For if concerns about suicidality come up. So the National Institute of Mental Health has a resource called the Ask Suicide Screening Questions. And this is valid for people 8 years of age and older. So it even goes to younger ages, where you can ask specific yes/no questions, and it gives you guidance on what to do if certain questions are answered positively or negatively. And through this toolkit that they have online that's free and accessible, it has a lot of other resources on what to do next and kind of next steps in planning. But in general, For when we're assessing suicidality, we want to know the nature of the past and present thoughts and behaviors. What have those looked like? What have the thoughts actually been? The time frame that it's happened over, the frequency of when it happens, the pattern. Are there triggers that make this happen more? Have they ever had a plan for suicide, either past or present? I usually avoid hypothetical questions because you tend to get weird responses. So not asking, if you were to kill yourself, what would you do? Because even I could come up with an answer for that, but it doesn't actually get at suicidality. And so I tend to say, do you have a specific plan? If you were if you specifically have thoughts of suicide, is there a specific plan on how you would do that? Assessing people's access to lethal means. So finding out, are there medications in the home? Are there weapons in the home where people could have access to? And then also asking, who knows about this? Who has been helpful to talk to? What has been helpful when you're feeling this way? Because it helps in kind of the next steps of planning. So when we're responding, it's good to know that no one can accurately predict suicide. Even experts in this field can only try to assess someone's risk. And one of the biggest things in identifying people's risk is finding out their intent. So really, what is the intent behind the thoughts and the plans that they are having to help you determine risk? And so this goes back to the definitions of passive and active suicidal ideation. Passive suicidal ideation, the more abstract thoughts around death, are much lower in risk than someone who has active SI and concrete plans on how they would carry that out. And so people who have a plan or a recent attempt, especially those with high probability of lethality, so if people are using firearms or things like that, then much higher risk of death. And if people have a current intent that they're stating to kill themselves, that is higher risk. Also, if people have recent ideation or behavior accompanied by acute agitation or severe hopelessness, or if people have underlying mental health or substance use issues, and then they have increased impulsivity and a profoundly dysphoric mood that can kind of push them towards suicidality. And so again, the most important thing is that we're trying to ensure safety. And so for you're determining, does this person need intermediate intervention right now? I'm worried about their physical safety right now. Or are we going to be continuing down further outpatient care and follow-up? And so in immediate intervention, one thing to always remember is if you have access to mental health professionals, either at your site or that your patient works with, reaching out to those people. Don't forget that your colleagues are around to help, where they can talk with the patient also. Here in our division, we have therapists upstairs. We literally can call them down if we have a question on what's going on with a patient. Knowing that if there is an acute emergent problem where you're worried about safety, transferring them to the emergency department, or if you're in an outpatient clinic, calling 911 to have safe transportation to a safe setting. And then determining at that point then, will they potentially need to be admitted to the hospital or a treatment facility for further care and safety. For outpatient care, even if it's for standard depression or things like that, we want to do safety planning with parents and the family. And so these are things like talking about securing or removing firearms in the home, keeping medication safe, sharps, ropes, things that could be used in more lethal methods of suicide attempts, so then we can help to keep people safe. Also identifying good coping skills, what helps when you feel down, who does it help to talk to? You know, do you feel comfortable calling hotlines? Can we give you resources to really use when you're first starting to have these thoughts? And if you don't feel safe at any time, or if your parents do not feel like they can keep you safe, call 911 or go to the nearest emergency department. And so really it's just outlining that plan and documenting it in your note that this is what we discussed, this is what the plan's going to be. For COVID specific things on what they're recommending for mental health, especially for healthcare providers, one of the main things is training in suicide prevention and really culturally appropriate care, and also support for us, right? Support for healthcare staff and frontline workers, because as I'll get into here, there are some concerns about the treatment that we're providing during the pandemic. So we know there's overall lack of resources for mental health support, but now it's a lack of in-person, so even harder to connect. And so yes, telehealth is rolled out more, and it may increase access, but it may also exacerbate disparities on who can access based on technology access. We also are worried about privacy. You know, if they're at home and their parents are working from home, can they actually talk about these things? And the other aspect is we're all in this, right? therapists, doctors, everyone is also experiencing the same distress that their patients and clients are going through. So it can be extremely triggering to professionals, where we are at higher risk for burnout by even going through these things with patients. So keeping our own health in mind. There's a lot of resources for patients and families. This one from JAMA Pediatrics outlines the 3 key aspects, such as watching for warning signs of depression, providing support and resources, and preventing access to lethal means of suicide. Teen Line is a great local resource through Cedars-Sinai and D.D. Hirsch that is actually teens who talk to other teens when they're having issues. It's a hotline that they can call or text or chat online. They also have a Youth Yellow pages that has all different kind of resources, including mental health resources for youth to be able to access. And keeping in mind national suicide prevention lifelines that are available at all hours, including crisis text lines. For LGBTQ youth, I listed some resources, including our division. The Trevor Project and Trans Lifeline are 2 distress hotlines that are available for LGBTQ and specifically trans populations. And so they may feel more comfortable calling those. And then I also have some resources for providers. There are more resources in the pearls from the conference as well. But really, the AAP has a great page of depression resources, including the guidelines for adolescent depression and primary care toolkit, things like the PHQ-9, doing the screener for suicidality. And then there's 2 really good review articles that I think are good to read if you want a little bit more exposure. Also, actually, I got an email today, actually through Pediatric Care Online. They have a new toolkit that's available on mental health that was just updated. So a lot of resources available. Thank you for your attention, and I can take some questions and just reach out if you need anything.
Thank you so much. That was a great presentation. I know certainly on the inpatient side as well that we've really been kind of floored with a lot of the mental health concerns that we've been seeing in our hospitalized patients as well. So this is, very timely. I just wanted to share some of the questions that we received from Dr. Rajasekar. His question, he's actually, video's turned on, but so I guess you could speak for yourself, but I'll read your question in the chat, which is, do we see a difference, or do we know if there's a difference in instance of suicidality in urban versus suburban versus rural areas, and then also in different regions of the country, whether that's red versus blue states or South versus North versus Midwest, et cetera?
So I haven't seen, especially in youth, I have not seen data that's much more specific to, certain settings, certain populations. I think especially for risk of death by suicide, it's even lower just because of the number. The number just gets so much lower. I think that there has been a lot of research, or at least some research recently around everything with what's going on. I know you mentioned like red and blue states, right? With politics, especially in LGBTQ youth. We anecdotally have definitely seen with our, so in our transgender clinic, we have seen a lot of increase in internalized transphobia around what's happening politically or what has happened politically in the recent past. And so I think, as far as the concern about rural versus urban, I haven't seen specific data, but I would say that really a lot of things with different settings now, really a lot of it has to do with tend to be pretty similar in a lot of different settings. And so, it's like people at least have access to resources and people outside of their immediate setting, but definitely, I'm sure that there are differences that I just haven't seen.
Thanks. There was a question that may have been answered in the Q&A box by another panelist, I'm not sure, but I remember what it was, so I'll just ask, which is, what resources or what plan of action would you suggest for those who are practicing in clinics or private practices whose patients don't have immediate access to a psychologist or mental health services, but who maybe don't also seem to meet the requirements? I'm adding this part myself, but who maybe don't seem to meet the requirements to be sent to the emergency department or hospitalized urgently?
Yeah, I think it's a really, really tough situation right now. I think California has at least done some advocacy. There's actually legislative things happening around insurance coverage of mental health services. It's been one thing that's been hard, even at children's, even at large academic pediatric institutions where we do not have good infrastructure. Like at children's, we actually just got a very large endowment to even expand our own mental health services. So it's something that that what we've actually seen is for Medi-Cal patients, we have the Department of Mental Health. It's actually quite easy to get people in with mental health services. When people have PPO insurance, it gets very complicated because a lot of mental health providers are not contracted with insurance. A lot of them either don't accept insurance, or they'll do super billing where they will after the fact will try to get reimbursement for the family. So it can be extremely hard to get services no matter where you are. I think the most important thing is taking on what you can take on as a provider, right? Being able to at least check in with people, following people's, checking with people around ideation, around doing some of these assessments, because then it's knowing, okay, if someone decompensates, we can get them where they need to go. And in the meantime, trying to find someone to do more of the emotional intelligence building and the coping skill building. So I think doing as much of that as you can. The other thing right now, during the pandemic, a lot of insurances are covering telehealth services for therapy. As of right now, it ends March 31st for a lot of insurance companies. It may be extended, but that's been one thing for us that's been great is for people far, they can do telehealth, right? So it's again, increasing access. It might not be in person, but it's just finding out whatever you can.
Thank you very much.
I see a question in the chat that asked about the PET team. So, the PET team, or kind of like the psychiatric emergency response team. So in our clinic, we have not found the PET team to actually be a very efficient system. So the PET team, for those who aren't familiar, it's kind of a almost like an urgent response team who comes out specifically to do assessments around psychiatric emergencies. And so they have specific training. Sometimes they can determine if someone needs to go on a hold or not, if they need to go to the hospital or not. And so it's nice to have that evaluation. The issue, so for our clinic, anytime that we have called the PET team, it can take anywhere from 30 minutes to like 8 hours for them to come. It's extremely difficult to get them to come. And in our setting where we have restricted hours, we can't sit with youth until 10 or 11 p.m. To keep them safe during that whole time. And so for us, it has actually not been actually effective because I don't think the infrastructure is actually good enough to support the need. So it's a great idea, and it's a great thing that's there and that's available if you can try, but oftentimes they won't even give you an estimate and it'll just be hours and hours. And so for us in our clinic, our algorithm has really been, we're going to call 911 and let them know the situation, because that actually gets our patients the services they need. So it's not ideal, but it's at least what we have found from our experience.
All right. Thank you so much. That was really informative.
Of course. Thank you.